Syphilis is a sexually transmitted infection caused by the spirochete bacterium Treponema pallidum. It has distinct stages that can affect multiple organ systems. Let's break down its stage, clinical features, diagnosis, and treatment. This presentation is for educational purposes only. Syphilis is a sexually transmitted infection caused by the bacterium Treponema pallidum. It spreads mainly through sexual contact and from mother to child during pregnancy, known as congenital syphilis. This infection remains a significant global health issue due to its varied symptoms and potential complications if left untreated. Treponema pallidum, identified in 1905, is a slender, spiral-shaped bacterium with corkscrew motility. It is microaerophilic and fragile, making it impossible to culture on artificial media. Visualization is best achieved using darkfield microscopy, silver staining, or immunofluorescence techniques. Syphilis is endemic in many regions, with the highest rates in sub-Saharan Africa, Southeast Asia, and Latin America. In 2020, the WHO reported 7.1 million new cases globally. In the US, syphilis rates have been rising since 2000. Congenital syphilis remains a major concern, highlighting gaps in maternal screening and treatment. Syphilis transmission occurs through sexual contact, direct contact with infectious lesions, and from mother to child during pregnancy. Main risk factors include unprotected sex, multiple partners, and co-infection with HIV or other STIs. Rarely, it can spread through blood transfusion or sharing needles. Syphilis progresses through distinct stages if untreated: primary, secondary, latent, and tertiary. Neurosyphilis and ocular syphilis can occur at any stage. Understanding these stages is crucial for diagnosis and treatment. Primary syphilis typically develops about 3 weeks after exposure, though the incubation period can range from 10 to 90 days. Its hallmark feature is a painless ulcer known as a chancre, which appears at the site of inoculation, such as the genitals, mouth, rectum, or any other exposed area. The chancre is characterized by a clean base, firm raised edges, and is highly infectious. Regional lymphadenopathy often accompanies it, with nodes that are firm, rubbery, and non-tender. Although the chancre heals spontaneously within 3 to 6 weeks, the underlying infection persists and, if untreated, progresses to secondary syphilis. Secondary syphilis occurs weeks to months after the healing of the primary chancre, typically around 6 to 12 weeks, and represents a highly infectious stage of the disease. It is characterized by a diffuse, symmetric, non-itchy maculopapular rash that often involves the palms and soles, along with condyloma lata, which are raised wart-like lesions. Patients may also develop mucus patches in the mouth, throat, or genital areas, as well as moth-eaten alopecia. Systemic manifestations include generalized lymphadenopathy, fever, malaise, sore throat, and weight loss, while cerebrospinal fluid abnormalities are detected in up to 40% of cases during this stage. Less common features can include hepatitis, nephropathy, gastritis, proctitis, rectosigmoid mass, and arthritis, reflecting the widespread systemic involvement of this phase. Latent syphilis refers to an asymptomatic stage of infection where patients show no clinical signs of disease but have positive serologic tests. During this phase, syphilis can still be transmitted despite the absence of symptoms, particularly in the early latent stage, which occurs within 1 year of infection and is considered infectious. Late latent syphilis, defined as more than 1 year after infection, has much lower infectivity, though vertical transmission to a fetus remains possible. This stage may last for years or even decades before progressing to tertiary syphilis, underscoring the importance of screening and treatment even in the absence of symptoms. Tertiary syphilis develops years to decades after an untreated infection and is marked by destructive complications affecting multiple organ systems. Patients may develop gummas, which are raised rubbery granulomatous lesions on the skin, bones, or organs that can ulcerate, along with rashes, scarring, and chronic skin ulcers. Cardiovascular involvement includes aortitis, aortic aneurysm, aortic valve regurgitation, and coronary osteostenosis. Neurosyphilis may manifest as meningitis, tabes dorsalis, stroke, seizures, or progressive neurological deficits. The disease can also cause bone pain and deformities, as well as hepatic involvement with cirrhosis and gummas. This advanced stage represents the destructive long-term impact of untreated syphilis, often appearing 10 to 30 years after the initial infection. Neurosyphilis can develop at any stage of syphilis, with clinical forms clustering at different points. Early neurosyphilis, occurring within 1 to 2 years of infection, may present as asymptomatic disease with only cerebrospinal fluid abnormalities, meningeal involvement with headache, nausea, vomiting, cranial nerve palsies, and seizures, or meningovascular disease leading to stroke in young adults. Late neurosyphilis, typically manifesting 10 to 30 years after untreated infection, includes general paresis with neuropsychiatric decline and dementia, as well as tabes dorsalis characterized by spinal cord involvement, ataxia, lightning pains, and Argyll-Robertson pupils. Ocular syphilis can also occur at any stage but is most common in secondary or early neurosyphilis, presenting with uveitis, interstitial keratitis, retinitis, chorioretinitis, or scleritis. Early neurosyphilis may cause optic neuritis, neuroretinitis, and acute vision loss, while late disease may lead to gummatous ocular lesions, optic atrophy, and Argyll-Robertson pupils. The diagnosis of syphilis relies on a combination of clinical suspicion and laboratory methods, including darkfield microscopy, serologic testing, and lumbar puncture in suspected neurosyphilis. The two-step algorithm for syphilis diagnosis uses an initial screening test followed by a confirmatory treponemal or non-treponemal test to improve accuracy and reduce false results. Darkfield microscopy is a diagnostic technique that uses special illumination to directly visualize Treponema pallidum as thin, corkscrew-shaped, motile organisms. It is performed on serous fluid collected from a primary chancre or from moist secondary syphilis lesions, such as condyloma lata, making it most useful in the early stages of syphilis before serologic tests become positive. This method allows rapid bedside diagnosis, but its reliability is limited when oral or rectal specimens are used because of the presence of non-pathogenic spirochetes that can lead to false results. Serologic testing for syphilis relies on a combination of non-treponemal and treponemal tests, each serving different purposes. Non-treponemal tests such as VDRL and RPR detect antibodies against cardiolipin cholesterol lecithin antigen, become positive 1 to 2 weeks after a chancre appears, and are mainly used for screening and monitoring treatment response since titers fall after therapy. They can provide quantitative results to track disease activity or reinfection, but are prone to false positives in pregnancy, autoimmune disease, or infections, and false negatives in very early or late syphilis due to the prozone effect. Treponemal tests directed specifically against Treponema pallidum usually become positive earlier than non-treponemal tests in primary syphilis and are used for confirmation after a positive screen. While more specific, they remain positive for life and therefore cannot distinguish active from past infection. The traditional two-step diagnostic algorithm for syphilis begins with screening using a non-treponemal test such as RPR or VDRL. If the result is non-reactive and suspicion remains, testing should be repeated. A reactive RPR or VDRL requires confirmation with a treponemal test. If the non-treponemal test is positive but the treponemal test is negative, the result is considered a false positive and syphilis is unlikely. When both tests are positive, the patient may have current or past syphilis, treated or untreated. In active syphilis or in past cases without prior therapy or inadequate treatment, management follows the stage of disease. For those previously treated, comparison of RPR titers with earlier results is essential. High or rising titers suggest reinfection or treatment failure and require retreatment, while low or stable titers in a patient with a treatment history represent a serofast state that does not require retreatment but warrants monitoring to ensure no new symptoms or risks arise. The reverse sequence algorithm for syphilis, which is increasingly used in laboratories, begins with a treponemal test. A negative treponemal test indicates that syphilis is unlikely, although in cases of very early infection, repeat testing may be needed. If the treponemal test is positive, a reflex non-treponemal test such as RPR or VDRL is performed. When both treponemal and non-treponemal tests are positive, this suggests current or past syphilis, treated or untreated, and management depends on staging and treatment history. If the treponemal test is positive but the non-treponemal test is negative, possibilities include past treated syphilis, very early infection, latent syphilis, or a false positive treponemal result, so confirmation with a second treponemal test is recommended. A negative confirmatory treponemal test suggests the initial result was a false positive, while a positive confirmatory test supports a diagnosis of past treated syphilis, very early infection, or latent syphilis. The diagnosis of neurosyphilis should be considered in patients with neurologic, ocular, or otic symptoms, such as cranial nerve palsies, stroke in young adults, cognitive decline, tabes dorsalis, uveitis, hearing loss, or unexplained treatment failure. A cerebrospinal fluid examination via lumbar puncture is indicated, with findings typically including pleocytosis with lymphocytic predominance, elevated protein levels, and a reactive CSF VDRL, which, though highly specific, has limited sensitivity. CSF treponemal tests, such as FTA, ABS, and TPPA, are more sensitive but less specific, and are supportive when VDRL is negative. Serum treponemal and non-treponemal tests are almost always positive in neurosyphilis. Neuroimaging may reveal infarcts in meningovascular syphilis or cerebral atrophy in general paresis, though these are not diagnostic. The definitive diagnosis rests on a compatible clinical presentation combined with positive CSF, VDRL, or other CSF abnormalities, alongside positive treponemal serology. Diagnosis of syphilis varies by stage. Primary syphilis is best detected by direct methods, while secondary and latent stages rely on serology. Follow-up involves monitoring non-treponemal titers. Key points include the importance of direct detection in primary syphilis and CSF studies for neurosyphilis. The treatment of syphilis depends on the stage, with penicillin remaining the gold standard across all forms. For primary, secondary, and early latent syphilis less than 1 year in duration, a single intramuscular dose of benzathine penicillin, G 2.4 million units, is curative, with doxycycline, tetracycline, or ceftriaxone as alternatives in penicillin-allergic patients. Late latent syphilis or latent syphilis of unknown duration requires benzathine penicillin, G 2.4 million units intramuscularly weekly for 3 doses, while tertiary syphilis without neurosyphilis is managed with the same regimen after excluding CNS involvement. Neurosyphilis, ocular syphilis, and otic syphilis require aqueous crystalline penicillin G administered intravenously, either continuously at 18 to 24 million units per day, or as 3 to 4 million units every 4 hours for 10 to 14 days, with ceftriaxone as a cautious alternative. Congenital syphilis results from transplacental transmission of T. pallidum. Early signs include rhinitis and rash, while late signs feature Hutchinson's triad. Diagnosis involves maternal and infant serology. Treatment with penicillin is essential, alongside prevention through antenatal screening. This table summarizes syphilis stages, key features, diagnosis, and treatment. Primary syphilis is marked by a painless chancre with regional lymphadenopathy and is diagnosed by darkfield microscopy or PCR from the chancre with serologic confirmation and treated with a single intramuscular dose of benzathine penicillin. G. Secondary syphilis shows a diffuse rash, often involving the palms and soles, mucus patches, condyloma lata, alopecia, and systemic symptoms, diagnosed by serology and treated with the same single-dose regimen. Latent syphilis is asymptomatic and identified only by positive serology, with early latent treated as a single dose and late latent requiring 3 weekly doses of benzathine penicillin, G. Tertiary syphilis may present with gummas, cardiovascular disease such as aortitis and aneurysm, or neurologic complications diagnosed with serology and imaging, and treated with 3 weekly doses of benzathine penicillin G unless CNS involvement is present. Neurosyphilis and ocular syphilis can occur at any stage, manifesting with meningitis, tabes dorsalis, general paresis, uveitis, or vision loss, and require intravenous aqueous crystalline penicillin G for 10 to 14 days.
For more educational content, like, share, and subscribe to Quick IM with Dr. Aid. Your support helps us create even more valuable content for you.